Welcome all to the today's class. So today we are going to start with early pregnancy module. Today's topic is management of nausea and vomiting in pregnancy and hyperemesis gravidarum. It is Green-top Guideline number 69. So in every Green-top Guideline, there are key recommendations which are given in the beginning of the guideline, and you should always read those. Okay, and it's very easy also to go through all that uh, while you are revising the topics nearing to the examination. Okay, so what are the key recommendations regarding this nausea and vomiting in pregnancy? Basically, this nausea and vomiting of pregnancy is of two types depending upon the severity. One is a simple nausea vomiting of pregnancy, and another is a hyperemesis gravidarum. And there are two scores. One, these are objective and validated index pregnancy unique quantification of emesis, that is PUQE score, and another is a hyperemesis level prediction. So there are two scoring systems which we should know about this. One is a PUQE, pregnancy unique quantification of emesis, and second is hyperemesis level prediction, HELP. So if there is an SPA about the scoring system, you should know about these two scoring systems. Okay. Then ketonuria is not an indication for dehydration and should not be used to assess the severity. And most of the time it is our understanding or misunderstanding that if there is a ketonuria, that means it is a severe type of hyperemesis gravidarum. But as per this new guideline, ketonuria is not an indicator for dehydration and should not be used to assess the severity. Okay. So ketonuria per se will not affect the management lines, which we will see in the subsequently. There are first line antiemetics, which are mainly this doxylamine plus pyridoxine combination. And second one, antihistaminics and phenothiazines. Okay, so these are first line antiemetics, antihistaminics, phenothiazines, and doxylamine plus pyridoxine. Okay, in second line, you have two drugs. One is an ondansetron, second is a metoclopramide. And there are very specific things about the ondansetron and metoclopramide which you should remember, because there can be SB on this. Okay, so ondansetron is safe and effective. It is second line drug. If first line antiemetics are ineffective, small increase in the these drugs can be used, and there is a small increase in the absolute risk of orofacial clefting with ondansetron use in the first trimester, which should be balanced with the risk of poorly managed hyperemesis. So this risk is very, very small when it is used in the first trimester. There is a risk of orofacial cleft, but it is very small risk, and that we just need to consider. But that is why this drug can be used as a second line. It is considered safe and effective drug. Okay. So you have to balance the risk of poorly managed hyperemesis and the avoidance of the use of this drug. Second, about metoclopramide, it is also safe and effective and can be used alone or in combination with antiemetics. There is a risk of extrapyramidal effect, and slow bolus injection needs to be given over a period of 3 minutes. So when you give metoclopramide, you need to be aware of the extrapyramidal effect, and you have to be very careful. So if you have an option with metoclopramide, always see is there any option with slow injection over a period of 3 minutes. Okay, and it is going to be a second line. So when will you select? When the first line antiemetics are ineffective, and that also you have, if you are giving IV, then select slow injection. Okay, then coming to the IV fluids, the IV fluid of choice is a normal saline 0.9% with additional KCl in each bag, with administration which is guided by daily monitoring of the electrolytes. That is the most appropriate IV hydration. So this is also asked in the SBA, what is the IV fluid of choice? It is the 0.9% KCl. So if you have NaCl, that is sodium chloride, if you have a option normal saline 0.9%, they may give various options 0.45% and different strengths of they can confuse you. So it is always a 0.9% normal saline. Another is a 0.9% normal saline along with KCl. Okay, if this is the option, then you can select this one. Okay, so there may be two options. One is a normal saline and another NS with addition of KCl. Okay, and daily monitoring of the electrolytes is required, and this kind of treatment is given either in the ambulatory or in the inpatient care, that we will see in the subsequent slides. Okay. So what is the prevalence of nausea and vomiting in pregnancy? Again, this is an SBA. They can ask you. It is 90% of the women can have nausea and vomiting of pregnancy. It is one of the common indication for hospital indication, and hospital stay. Typically, it is 3 to 4 days of hospital stay. Okay. If you are using the older guideline, the prevalence was 80%, but the recent guideline says the updated version says 90%. So remember, so if the SBA is framed as per the old guidelines, you may have an option of 80% also. So whichever is an option that you can select. Okay. Then what is the definition? Nausea vomiting of pregnancy is defined as a symptom of nausea and vomiting during pregnancy when the onset is prior to 16 weeks of gestation and where there are no other causes. Okay. So the onset is typically before 16 weeks of gestation and there are no other causes. Okay. Hyperemesis gravidarum is a severe form of nausea and vomiting which affects between 0.3 to 3.6%. So I just mentioned about the prevalence. So when you read about this question on prevalence, you please see what they have asked, whether they have asked nausea and vomiting of pregnancy or whether they are asking prevalence of hyperemesis gravidarum. The hyperemesis gravidarum prevalence they have mentioned is a 0.3 to 3.6% and 90% about the nausea and vomiting of pregnancy. Okay. So and not only that, there is a recent change in the definition. This hyper of life. So alteration of the quality of life and ability to eat and drink normally gets affected. So hyperemesis gravidarum is a severe form of nausea and vomiting which affects the quality of life and ability to drink and eat normally. So that is what is the definition. Okay. So this particular change as compared to the previous guideline, you should note that this guideline has given the importance of the quality of life. The criteria is no more used for the severity of the assessment, and the simple nausea and vomiting 90% prevalence. Okay. Now coming to the mechanism, again here there can be SBA which can be asked. Mechanism of nausea and vomiting, there is a hypersensitivity to the vomiting hormone growth differentiation factor 15. Okay, GDF 15. So this factor they have identified. This GDF 15 causes loss of appetite, taste aversion, nausea, vomiting, and weight loss. Okay, so one of the mechanism which is proposed is a hypersensitivity to vomiting hormone growth differentiation factor 15, GDF 15. Remember for SBA point of view, because it leads to the loss of appetite, taste aversion, nausea, vomiting, and weight loss. So hyperemesis gravidarum can be diagnosed when symptoms start early in pregnancy. Nausea and vomiting are severe enough to cause an inability to eat, drink normally, and strongly limits daily activities of living. Signs of dehydration are contributing to diagnosis. Okay, so here the patient is unable to eat and drink, and there is a limitation of the activity, and our signs of dehydration are contributory. Okay, so there are additional findings to this. Okay, so this definition represents a shift from historic reliance on the objective measures such as weight loss and electrolyte imbalance. So as per the previous guidelines, the weight loss was taken into consideration. The electrolyte imbalance was taken into consideration. Okay, but here is mainly the history and this quality of life alteration. These are given the more importance as per the updated guide. Now coming to the scores, which we have already discussed. Two scores are there. So PUQE, pregnancy unit quantification of MSC score, can be used to determine whether nausea vomiting of pregnancy is mild, moderate, or severe. Okay, so this PUQE is used one for quantification. Okay, and second to assess the response to the treatment. Okay, so but PUQE score can also be used to assess the response to the treatment for mild to moderate NVP, but it is not valid for severe nausea vomiting of pregnancy and hyperemesis gravidarum. So when you have a mild to moderate case, this you can do the severity assessment by using this score in mild to moderate cases, but not the severe or in hyperemesis. Second score is a HELP, hyperemesis level prediction score. So to quantify the hyperemesis gravidarum symptoms into score that can be trended over time to monitor the progress and response to the treatment. So this can be used for all grades. Okay, HELP, that is the only difference. Okay. So nausea, vomiting of pregnancy and hyperemesis gravidarum are associated with Now, what are the biochemical changes? So again, this is one of the questions which is frequently asked in the SBA. Okay, hyponatremia. What are the changes you get? Hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria with a metabolic hypochloremic alkalosis. So generally they ask you about these changes. They can give you in combination only hyponatremia with hypokalemia with low serum urea, hyponatremia, hyperkalemia, increased serum urea, hyponatremia, hypokalemia, and low serum urea. So these types of combinations are given. So exactly what is happening, you should know is these electrolytes are reduced. That is sodium, potassium, and even the urea level is reduced. What is increased is the hematocrit count is increased, and there is a ketonuria. And as far as the metabolic change is concerned, it is a metabolic hypochloremic alkalosis because acid is going out. So patient is vomiting. Okay, so it leads to metabolic hypochloremic alkalosis. Sorry. Okay, and only in severe cases there will be metabolic acidosis which can develop. Okay, in 2/3 of patients, that is 67% of women with hyperemesis gravidarum, there may be abnormal thyroid function test. So these are SBS. There are many SBS here on this particular slide. You can take the photograph, and after finishing the lecture itself, you need to take the notes of this. Okay, because these SBS, when you are revising, you don't have time to go through the guideline as such. Because morning I have posted this particular guideline in the group. You should read the guideline first. So when you listen to the lecture, you will grasp the things very easily. Okay, so here they can ask you the questions about these biochemical changes. They can ask you about this, what is the acid-base balance which is happening in the hyperemesis gravidarum. In severe metabolic acidosis, in severe cases, there may be metabolic acidosis also. And what is happening to thyroid function test? In 2/3 of cases, abnormal thyroid function tests are seen. So again, this is SBA. Abnormal thyroid function tests are seen in dash percentage of cases. It is 67% of cases. Okay, what you get changed is a raised T4 and low TSH in hyperemesis gravidarum do not need treatment, and straightforward nausea, vomiting of pregnancy where the cause is clear and the patient is responding. So this is one of the concept. This picture of altered thyroid function with raised T4 and reduced TSH, if it is purely because of hyperemesis gravidarum, it does not need a treatment. Okay, so they may give you a short scenario with alteration in this. In that particular case, this is because of the hyperemesis gravidarum. So you need to treat the hyperemesis gravidarum, and no separate treatment is required for the abnormal thyroid function test. Okay, so LFTs are abnormal in 40% of patients. So TFTs are abnormal in 67% of patients. LFTs are abnormal in 40%. So these percentages, please note it down for SBA point of view. Okay, with most likely abnormality being rise in transaminases. So where exactly the LFTs are abnormal? Mainly in the transaminases. Okay. So how should these women with nausea, vomiting of pregnancy and hyperemesis gravidarum should be cared for? Okay, so there are basically 3 settings. Okay, at the end of this PowerPoint, I'll go through these settings also. One is a community care, second is ambulatory care, and third is an inpatient care. Okay, so here first is community care, then you have ambulatory care, and then you have inpatient care. Okay, now depending upon this PUQE score, they have divided which patients will go where. Okay, now it is mild, moderate, and severe. Okay, so score up to 12 is moderate. Okay, more 13 or more is severe. Okay, so up to 6 is mild, 7 to 12 is moderate, and more than 13 is severe. When it is a severe, it will either go into the ambulatory care or inpatient care. Okay, but up to 12 you can manage in the community care. Again, this is one of the SBA. They may give you the score and they will ask you the what will be the care for this particular patient, whether she will be treated in the community or whether she will be treated in ambulatory, and what kind of treatment she will receive. Okay, so this concept is going to be very, very important. It will be more clear when you go through this last couple of charts and the slides. Okay, just remember that there are 3 types of setting. One is a community care with antiemetics. Here, the oral kind of treatment will be given. You will be encouraging the patient to take orally and will give antiemetics. Ambulatory care, where you are going to give intravenous fluids also, but we are evaluating the patient also, but we are not admitting the patient. While inpatient care, there is a more extensive evaluation as well as IV fluids, IV antiemetics are given. Okay. So what are the indications for inpatient care? So continued nausea and vomiting of pregnancy and inability to keep down at oral antiemetics. Continued nausea and vomiting of pregnancy associated with clinical dehydration or weight loss. So if you have given these particular things, that there is a clinical dehydration and weight loss more than 5% of the body weight despite oral antiemetics, you will select this inpatient care. Okay. Confirm or suspected comorbidity like UTI or inability to tolerate oral antibiotics. Comorbidities, especially epilepsy, diabetes, HIV, hypoadrenalism, or psychiatric disease, where symptoms and inability to tolerate oral intake and medication could present further complications. So when your patient have got nausea and vomiting of pregnancy and she is not able to take anything orally or not responding to oral antiemetics, then this nausea and vomiting is associated with clinical dehydration or weight loss more than 5%. When you have associated comorbidities such as urinary tract infection, patient requires oral antibiotics which is not able to tolerate orally, or there is a existing medical condition like epilepsy, these patients will require inpatient admission. So when you are given a scenario, please read the scenario carefully. What exactly they have given. Look for the comorbidity. Okay. See, the score may be less, but if it is associated with comorbidity, then you have to select the inpatient care. Okay. So that is how you should select the where the patient will receive the care for hyperemesis gravidarum. Where inpatient care is required, an ultrasound can be scheduled to confirm the viability and gestational age and to assess for multiple pregnancy or tropoplastic disease. So these particular two conditions you need to rule out in patients with hyperemesis gravidarum. One is a multiple pregnancy, second is a GTD, that is tropoplastic, gestational tropoplastic disease. And is it an urgent scan? No, you don't have to do urgent scan. It is a routine scan because this particular condition you need to stabilize the patient, and because patient is not bleeding here. Okay, so these are the routine scanning which you need to schedule. Okay. So I hope you have understood the indications for inpatient care and the settings where the patient is supposed to receive this care. Okay. So when no response to the single antiemetic, what you will do? Use combination of the drugs. Okay. Only licensed treatment of nausea and vomiting in the pregnancy is a delayed release combination of doxylamine plus pyridoxine. That is the only licensed treatment for nausea and vomiting. It is a delayed release combination of doxylamine plus pyridoxine. Okay. And it is the first line treatment for mild to moderate nausea and vomiting. So when you are managing the patients in the community care with oral antiemetics, you will select this doxylamine plus pyridoxine. Okay. So for women with persistent or severe hyperemesis gravidarum, the parenteral or transdermal or rectal route may be necessary and more effective than the oral regimen. Okay. Corticosteroids should be reserved for cases where the standard therapies have been ineffective and used in combination with antiemetics. So the we have seen the first line is this doxylamine plus pyridoxine. In second line, there are two drugs, and this corticosteroids comes in the third line. So it is a reserved drug for cases where standard therapies have been ineffective and it is used in combination with antiemetics. The dose for the steroids is a hydrocortisone. You will start 100 milligram BD. Okay, so you will give first intravenously, and once there is a clinical improvement, then you will convert it orally around 40 to 50 milligram per day, and then gradually you will taper it per week around 10 milligram you need to reduce. Okay. Then you maintain generally this hyperemesis, it takes around 16 to 20 weeks for these patients to recover from this hyperemesis. So till that time you will continue and you will taper and then you will not stop suddenly. Okay. And few patients may require for a longer time also. So prednisolone needs to be continued until the gestational at which a hyperemesis gravidarum should have been resolved, and in extreme cases prednisolone is continued until birth. Okay. So women receiving corticosteroids should be screened for GDM. So if you are given a scenario, please look into that. You need to screen these patients for development of the GDM. Okay. And tapering will be required. So these particular concepts you should remember. There can be EMQ also on this particular topic. Then what is the safety of pharmacological agents used to treat nausea and vomiting of pregnancy and hyperemesis gravidarum? The first line drugs we have already discussed. Antihistaminics are there. Then you have this doxylamine paradoxin combination. Phenothiazine group is there. So they are very safe. The safety data for antiemetics such as antihistaminics, phenothiazines, and pyridoxine doxylamine therapy, there is a safety data, and they should be prescribed initially when required for nausea, vomiting of pregnancy and hyperemesis. Then in second line, you have two drugs, ondansetron and metoclopramide. So ondansetron, we have seen that we need to counsel the patient about very small increase in the absolute risk of orofacial cleft with ondansetron use in the first trimester, which should be balanced with the risk of poorly managed hyperemesis gravidarum. The risk is very, very small, 11 per 10,000 births to 14. So 11 to 14 per 10,000 births, that is such a small risk is there. Okay, but you can counsel the patient. Second drug is a metoclopramide. It is safe and can be used either alone or in combination with other antiemetics. Because of the risk of extrapyramidal effects, metoclopramide should be reserved as a second line, and IV doses you have to give over a period of 3 minutes. Okay, women should not be prescribed medications that have caused previous adverse reaction. Okay, so if she has had previous reaction to any of these drugs, then you should not use this particular drug. So what adverse effects can occur and how to manage this? Okay, so nausea and vomiting can be associated with electrolyte imbalance. So you need to monitor urea and electrolytes daily. Okay, in patients who require IV fluids. So once the patient is given the inpatient care, you will monitor this. The fluid of choice will be 0.9%. 0.9% normal saline along with KCl and daily monitoring of the urea and electrolytes. Then recurrent intractable vomiting may lead to gastroesophageal reflux disease, esophagitis, or gastritis. So here the treatment of choice will be histamine type 2 receptor blocker, H2 blockers will use, or proton pump inhibitors, PPI, can be used for women developing GARD. Okay. Then nausea vomiting of pregnancy can lead to wernicke's encephalopathy due to vitamin B1 deficiency, that is thiamine deficiency. So we have to treat this with thiamine supplementation. Remember the dose, either orally 100 milligram TDS, or you can give IV also to all women admitted with vomiting or severely reduced dietary intake, especially before administration of dextrose or parenteral nutrition. So it has been observed this wernicke's encephalopathy, it gets precipitated in patients who receive dextrose. That is why the first drug of choice is IV fluid of choice is a 0.9% normal saline. If at all the dextrose is to be given, this has to be given along with thiamine supplementation to all women who are admitted with vomiting or severely reduced dietary intake, especially before administration of dextrose or parenteral nutrition. Okay, so thiamine has to be component of that. The second, GARD treatment, add PPI along with antiemetics. Okay, so proton pump inhibitor treatment improves this pregnancy unit quantification score and improves quality of life score. Okay, now this PUQE 24, it doesn't mean the total score is 24. This score is calculated for the symptoms which are present in the last 24 hours. So you are asking few questions to the patient regarding last 24 hours, and then you calculate the score. Okay, so the score is around 15. Okay, so less than 6 is, up to 6 is mild, then up to 12 is moderate, more than 13 is the severe score. Okay, then further, women with hyperemesis gravidarum have increased risk of VTA. So regarding VTA, what is the guideline says? Thromboprophylaxis. When you are admitting these patients, you have to get thromboprophylaxis for these patients, but the thromboprophylaxis is restricted for the duration of hospitalization. When the patient is in the hospital, only after that you will stop this thromboprophylaxis. Okay, so you may have a question from VT component also, section also, or it may be from early pregnancy module also. Okay, now oral iron can lead to the nausea and vomiting and constipation, so it should be avoided in the first trimester, or it should be avoided in these patients. So previous or current nausea and vomiting of pregnancy or hyperemesis gravidarum should consider avoiding iron containing preparations if these exacerbate symptoms or consider alternative route of administering iron. So these patients you have to, if at all iron is required, you will choose alternative route, not the oral route. Okay. They commonly suffer with these patients commonly suffer with constipation because of reduced food and fluid intake, and if treated with ondansetron. So you need to offer laxatives if constipated, particularly if ondansetron is used. Okay. So ondansetron, there are two things we have seen. One is orofacial cleft. The prevalence is around 11 to 14 per thousand, 10,000. And second is it can lead to the constipation. So you have to use laxative. Okay. And it is a second line drug. So I hope this first line, second line is very clear. Third line, we have seen corticosteroids. Initially IV 100 milligram BD, then you will convert orally 40 to 50 milligram. Then you will taper weekly. Okay, 10 milligram each. You will continue till the symptoms subside. And very rarely you may have to continue till birth also. This is what is the thing. Now, what adverse effects can occur from nausea, vomiting of pregnancy, and how it can be prevented? Okay. Now, about this further investigation, OGD-scopy is safe in pregnancy and indicated in cases of hematemesis or severe epigastric pain. So if you have a scenario where there is hematemesis, then the investigation of choice will be OGD-scopy, that is esophageal-gastroduodenoscopy. It is safe. Okay. The therapeutic trial with PPI is appropriate for treatment and prevention, and it is safe in pregnancy. So for prevention of this, you can use PPI. Okay, proton pump inhibitor. Second is Wernicke's encephalopathy due to B1 deficiency, classically seen in seen as a patient will present with a blurred vision, unsteadiness, confusion, memory loss, drowsiness, and on examination you will find nystagmus, ophthalmoplegia, hyporeflexia, avreflexia, gait, finger nose ataxia will be present. In hyperemesis gravidarum, the presentation tends to be episodic and of slow onset. So this is over a period of time the patient will have these symptoms like blurring of vision, unsteadiness, then the gait will be changed. Okay. Finger nose ataxia will be there. So these you need to look for neurological symptoms also. And Wernicke's encephalopathy is a potentially fatal medical emergency. In the context of hyperemesis gravidarum, it is preventable. Remember, it is preventable condition, and its association with IV dextrose and parenteral nutrition is known. Okay, almost 1/3 of women will be readmitted within the same. Now, what is the recurrence of this hyperemesis? These patients who you admit, 1/3 will again require admission in the same pregnancy. Okay. So this is what is the thing about inpatient management and Wernicke's encephalopathy. Okay. Now, what is the optimal rehydration regimen for ambulatory inpatient? So community management is mainly with the oral antiemetics and encouraging her to take the fluid orally. While ambulatory and inpatient, both will have score of more than 13. Okay. But in 13 also, which patients will go for ambulatory and which patient will go for inpatient, that also we will see in the subsequent slide. But these patients require intravenous fluid management. So 9.9% saline with addition of KCl or potassium chloride in each bag with administration which is guided by daily monitoring of electrolytes. Use of dextrose infusion for fluid replacement in these patients are to be avoided. It may precipitate Wernicke's encephalopathy in thiamine deficient state. Then, what is the role of enteral and parenteral nutrition when it is to be started and risk to the woman and fetus? So, parenteral nutrition should only be considered as a multidisciplinary approach when all other treatments have failed to sufficiently control the symptoms, as it is inconvenient, expensive, and can be associated with serious complications such as thrombosis, metabolic disturbance, and infection. Okay, so it is a reserved treatment. Parenteral nutrition is a reserved treatment. It is given in multidisciplinary setting. So only in patients you can give when other previous treatment has failed. Okay. Now there are treatment modalities like you can go for enteral tube feeding, which may be nasogastric, nasoduodenal, or nasojejunal tube. Okay. Or second is a percutaneous endoscopic gastrostomy or gastrojejunectomy feeding. All of which should only be considered in consultation with gastroenterology and with multidisciplinary approach. So you need to have multidisciplinary involvement, especially from the gastroenterology. Okay, you need to take opinion and you go for enteral tube feeding. Okay, then parenteral feeding with PICC, that is peripherally inserted central catheter line, is often better tolerated than enteral tube feeding. However, it carries higher risk of infection and vascular complications. So you have one option of enteral tube feeding, and second is a parenteral feeding with PICC, PIC line. Okay, but the PIC line is, though it is better, it carries higher risk of infection and vascular complication. Okay. Now, when to terminate the pregnancy? The pregnancy is almost 10% of women can will require termination of the pregnancy. Okay, and this is mainly due to the severity of symptoms who otherwise would not have undergone termination of pregnancy, and this is exclusively due to the hyperemesis gravidarum. Okay. So, when should we consider termination? So, treatment options will include normally antiemetics, corticosteroids, enteral, parenteral feeding, and correction of electrolyte and metabolic disturbances. If we have done everything, then and still it is persistent, then only we may think of the termination of pregnancy. Okay, so when the patient is not getting control, always look for the next step, and this is the last step when the patient is not responding to antiemetics, corticosteroids, enteral or parenteral feeding, and correction of electrolyte and metabolic disturbances. Okay, then you will think of termination of pregnancy. Before termination, you need to take a psychiatric opinion if there are concerns regarding mental health, and decision for termination of pregnancy needs to be multidisciplinary with documentation of therapeutic failure if this is the reason for termination. So you need to document that there is a treatment failure and you have followed this stepwise approach. You have taken psychiatric opinion, mental health. This is also very, very important because mental health, lots of mental health questions are asked nowadays in the RCOG examination. So maybe this could be one of the patient will require a multidisciplinary approach, gastroenterology opinion. If this parental treatment has also failed, you will also take a psychiatric opinion. If you have done everything, then you document this and go for a decision for the termination of the pregnancy. Now, are there any long-term effects of nausea and vomiting of pregnancy in hyperemesis gravidarum? Women who experience hyperemesis gravidarum in pregnancy are at increased risk of mental health disorders such as postnatal depression, anxiety, and post traumatic stress disorder. Okay, so in these patients, these are the things which are seen. Postnatal depression is common, anxiety is common, and PTSD. Okay, post traumatic stress disorder. Now, what is the risk of recurrence in future pregnancy? It is 15 to 81%. Okay, that is what is the risk of recurrence of nausea and vomiting in pregnancy. A low recurrence risk with preemptive antiemetics before symptoms begin. So, if there is a history in a previous pregnancy of hyperemesis gravidarum, then you can start antiemetics before the symptoms begin. So this can be one of the SBA or EMQ. Okay, so what you have to do, if there is such a history, you will start early antiemetics in these patients. Okay, and these patients are known to have these mental health disorder like postnatal depression, anxiety, and post-traumatic stress disorder in the postpartum period. Risk of recurrence, please remember this figure, 15 to 81%. Okay, so this is the score which we were talking about. This is a pregnancy unique quantification score. Okay, these are the symptoms in last 24 hours. Mild is up to 6, moderate is 7 to 12, and severe total score is 15. So 13 to 15 is a severe. So there are basically three questions. One is about in last 24 hours presence of nausea. Last 24 hours patient is having vomiting, and last 24 hours having hard retching or dry heaves. Okay, so then this is scored. So they will not ask you to score, but this you should know. What is the interpretation of the score? And these are the additional questions. Okay, whether she was getting adequately sleep or not, and how she will rate her well-being and all. Okay, but the score is calculated from this. The total score is 15, severity is 13 to 15. Okay, now according to this score, we should select the care. Okay, settings, care settings we need to select. This is the HELP score. Okay, hyperemesis level prediction. Again, this will not be asked, but these are the histories which are we need to ask, or questions which we need to ask, and we have to do the total of each column. Okay, and then we have to calculate the score. Okay, so finally you will do the total of all columns. Okay, in each column you will do the score, and finally you will do the total of all columns. So if it is 19 or less, it is mild, 20 to 32, it is moderate, and 33 to 60, it is severe. Okay, so this is what is about HELP score. Okay. Now, these are the drugs. This we have gone already into details. The first line of choice is doxylamine plus pyridoxine. Remember, this dose is 20 milli. This 20 milligrams of doxylamine, 20 milligrams of pyridoxine per oral at night. Okay, you can increase additional 10, one in the morning and one in the lunchtime also. So you can start double dose at night, then add one in the morning, one in at lunchtime, and double. So that you can do. Okay. Then second is a cyclizine. This can be given oral plus IV also. These are the PZ, yes, PCZ is there, PZ is there, and CPZ is there. Prochlorperazine, promethazine, and chlorpromazine. Okay, they are not asking the doses as such, so you need not remember these total doses, but which drug in which line, first line, second line, that you should remember. Second line, we have seen two drugs. Okay, metoclopramide. Here they have mentioned three drugs: metoclopramide and ondansetron. Third one is a domperidone also. Okay. Then third line, we have seen corticosteroids, hydrocortisone. How to give that also we have seen. So I will not go into the details. Okay. And these appendix are given at the end. So most of the time we don't read these appendix, but this appendix, from this appendix also there are questions which are asked. So these are the investigations which we need to do in patients with hyperemesis gravidarum, especially concentrate on this electrolyte imbalance, because they are asking on this particular electrolyte imbalance. Okay. And in ultrasound, you need to one, you will look for the viability, then multiple pregnancy and trophoblastic diseases. Okay. And in refractory cases, TFTs, LFTs, calcium phosphate, amylase, etc., they are required. Okay. So this is what is the line of management. How the patient is initially assessed and the line of management is decided. Okay. So you have to first diagnosis and severity of the assessment. You will calculate the this PUQE score. Okay. Then according to the score, if the score is up to 12, she will be managed in the community. Okay. You will give antiemetic therapy, support and reassure, encourage oral hydration, offer dietary advice, consider use of laxative if required, prescribe H2 receptor blocker or PPI if women develop GORD, and mental health assessment or referral to the parenteral mental health services when required. So these are the things which you can do in the community. Okay, it is mainly oral antiemetic treatment, and if required, you add PPI or H2 blocker and mental health assessment. You will assess these patients after 24 to 72 hours. Remember, when you start this particular single drug antiemetic, and you will assess if there is minimal or no response, then you will add second or third antiemetic. Okay, so combination is you have to give in the community care itself. You don't have to refer. So if the patient is not responding to single line treatment in the community, you will add drug in the community itself. Okay, when up titrating, add drugs as opposed to the replacing them. So because when they ask you what will be the next step, you should remember this, when to refer. Okay, if the patient is improving with this, you will manage this patient in the community. Now, if the patient is not responding, you will add second or third antiemetics. You will titrate, and while titrating, you have to remember you will not replace the drug. You will add the drug. Okay, and refer to the, if the patient, if there are red flags, then you will refer. Okay, and remember the referral is given from this ambulatory to here directly. Okay, because the patient is managed either in the community or ambulatory or this. And now the score more than 13 is either ambulatory or inpatient. Okay, now which patient for ambulatory and which patient for inpatient care? Okay, so when you have a score of more than or equal to 13, but there are no complications, okay, inability to tolerate oral intake and community measures failed. Okay, so if there is a here community measures these patients, but they should not have any complications. Okay, if there are complications, she goes here, and from here she will be these patients will go for ambulatory care. Okay, so if, when you have a score of 13 or more, but there are no complication, there is inability to tolerate oral intake and the community measures have failed. Okay, but these patients should not have any complication. Okay, then red flag if they are present, like if any PQE score, as I already mentioned, her PUQE score may be 8, 9 also, but if there are complications, she requires inpatient management. Okay, inability to tolerate oral intake. She is not responding to outpatient management. There is a clinically dehydration, weight loss 5%. So if the scenario gives these particular things, you will select the inpatient management. If there is a confirmed or suspected comorbidity, or the comorbidity and unable to take medications, like she is a known case of epilepsy, HIV, etc., etc. She is on certain medications and not able to take these medications, you will directly go for inpatient management. And if there are concerns regarding mental health, she requires inpatient management. Okay. So this is the way the patient is managed in the general practice. Okay. So you need to evaluate these patients' initial assessment. Okay. You need to confirm the diagnosis and severity. And this is what we have already seen, how the patient is managed in the community. Okay. Which patients require ambulatory care. This is the same which we have just discussed. And that also tells about the drugs which we have gone into the details. Okay. While you are changing the antiemetics, it is not changing, you need to add. Okay, select first line, then you add if there is no response. Do not replace. So these are the certain things which you need to remember. Okay, and postpartum, you need to remember that these patients are high risk for PND, postnatal depression, then post-traumatic stress disorder and anxiety. Okay, and recurrence risk is 15 to 81%. Then same thing is about ambulatory care. So you will confirm the diagnosis. Okay, then assessment you will do, you will calculate the score, and these patients who are in ambulatory, you will treat it with IV fluids and IV antiemetics. Okay, and you will also add thiamine supplementation. This drug is chart is same doses what we have done. Yes, if there are red flags, you will go for inpatient care. Okay. And third one is the emergency department management. This is same. Okay, only thing is that here you need to evaluate these patients properly, and line of management is same. Okay, this is the inpatient. So this is the emergency department management. Here, if you see that these are the investigations: urine dipsticks, urea electrolytes, BC, blood glucose. You also have to do amylase and venous blood gas. You need to do. Okay, so these investigations, including the amylase, blood glucose, you have to do here in the emergency department. Okay, so these investigations are same in the ambulatory care and in the emergency department. Once the patient is admitted, then additional investigation, because the patient will be refractory, so you have to do TFT also, LFT also, bone profile, amylase, and VBG. So this is the only difference here between the emergency management and the this inpatient management. Okay. Otherwise, rest of the treatment, once the patient is inpatient, you will give IV or IM antiemetics. The fluid of choice will be 0.9% normal saline, and you will always add thiamine. Okay, you will continue with thromboprophylaxis and prescribe H2 blockers or PPI. Okay, this you will continue. The drugs we have already seen. On discharge, up titrate antiemetic therapy. They encourage oral hydration and offer dietary advice and provide contact numbers for early. So this is same everything. Okay, so that finishes the topic about hyperemesis gravidarum. Thank you.